My name is Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation. Tonight, we have a tremendous panelist group, and we are going to talk about adopting the TMINI in your practice. If you don't know what the TMINI is, you will know about it by the time this night ends because we have followed a tremendous number of innovations this year, over the last 4 years in the journal. And this is one of the most exciting ones that we've encountered. And I'm so happy for the faculty and for everybody who's joined us tonight. I'd like to have the faculty introduce themselves. We'll start with James Womack. Please introduce yourself, James.
Thank you. Thank you very much for having me. I'm James Womack. I'm out of Clinton, Missouri, just south of Kansas City. Did my training in Wichita, Kansas with David McQueen and Jack Sherman doing total joints. Have been in practice about 13 years here in Clinton and adopted robotics about 7 years ago, and then have been doing the TMINI for going between 6 months and a year now. So really exciting stuff.
Great, great. And I think we have Shawn Hocker. Shawn, you want to introduce yourself now?
Sure. My name's Shawn Hocker. I'm joining you from Wilmington, North Carolina. I'm in my 18th year of practice. I trained at Duke, did my fellowship with Aaron Hoffman in Utah. Also did a sports medicine fellowship. So I do a fair amount of shoulder arthroplasty. Helped develop software for computer navigation in my fellowship, which is now adopted for the robotics system in Rosa. So I've been in the navigated space for a while. Was waiting for a platform like TMINI with an open agnostic platform to get me engaged. And so I've been involved in this now for the past 4 or 5 months and excited to be here. Thank you.
Excellent. And Alexander Shaw, all the way
Yes,
out from California.
that's right. We have all the coasts represented. So thank you, Ira, for putting this together. Always a pleasure to be on this platform. You get such a great audience and a great topic. As you said, for those who know TMINI or don't, hopefully we'll learn a lot this evening. And I was trained in Philadelphia, did med school there, then did residency at Harvard and Boston, then did my joint fellowship at Rush in Chicago before settling back into Fremont, California, where I was born and raised. So do exclusively hip and knee replacements here. And I was a little bit hesitant to jump on board of robotics when it first came out, largely because of the problems with traditional robotic systems. We'll probably talk about this evening in terms of just how cumbersome they can be and how large they can be and how they can affect your typical workflow. So I was a little bit later to the game, but started to do robotic technologies with various systems probably 3 or 4 years ago, but then was fortunate to work with Think Surgical because they're based here in Fremont actually as well. So where I practice, and so was involved and put in some of their first knee implants a little over a year ago, and then some of the first with their partnership with Zimmer Biomet just this month. So I've had a lot of experience with it and look forward to having a discussion about its utility.
Excellent. I'd like to start with you, Alex. You do hip and knee exclusively at a general hospital and an ASC. Explain to me sort of the when and why you adopted the robotics and the TMINI and how it has sort of weaved itself into your ASC.
Absolutely. It's a great question. Typically, with traditional robotic systems, at least in our practice, they were first introduced in the main hospital, mainly because there were capital expense or challenges to obtain the robotic platform. So it made sense for large hospital systems to obtain the robots. So naturally, you're often doing them on your inpatients or if you're sending people home same day, but from the main hospital. So that's where our initial robotic platforms were placed. Certainly the interest in the Bay Area, Silicon Valley, a lot of people are interested in robotic technologies and advanced technologies and how to do knee replacements potentially even better with more accuracy and precision. So patients are asking for it. And so that's really why we became involved with it. The Think Surgical TMINI system obviously gave us many advantages when it became available, such as its lower profile, easier to use for the staff, much more time neutral, being handheld and wireless and not disturbing our typical workflows, that it was a natural adoption once it became available to bring into our hospital. So that's where we did do it first, because really we're doing all comers with that robotic technology. But of course, simultaneously, more and more joint replacement surgeries are occurring in the ASC. And so it was a natural transition for us to have a robot at our ASC as well. And really, many of its benefits shine through even more in the ASC setting, meaning it's lower profile, right? It's just one base station. It's only a single tray that you have to turn over, and the robot itself fits in one tray. So for a small ASC, you don't have large robots taking up a lot of space or small ORs being bothered by having large footprints. So in our ASC, we're able to do as many cases as we want to, 8 joints in a day, and be done and have rapid turnover. And in the main hospital, we can do our 10 to 12 joints and have our TMINI cases also turn over very rapidly, going from room to room. So we found it to be effective in both facilities.
Jim, what has been your experience with well, for lack of a better word, the big box robots versus the mini handheld? And because you started with the Rose, I think you said, right, Jim?
I started with Mako, yes, sir.
Oh, Mako.
And I mean, I completely agree with Alex in that, the smaller footprint compared to the big box robot, moving from room to room, the capital expenditure. So all of those things kind of really helped it make its way into our hospital. So one, we really like the idea of it being implant agnostic, so that we could, keep multiple surgeons happy if necessary. Also, with a smaller footprint, it's so much easier in a small hospital to store, to move from room to room, versus if I were doing Makos, it was, the same room, really didn't jump room to room because it was just so big and so bulky. Plus, when you get your assistant, the anesthesia and all them, it takes a lot of room just to put the robot in the room. And then I think one of the biggest advantages to TMINI, especially when you get your hands on it, is just line of sight. When you think about the robots that have the line of sight coming in from the side of the room, either you or your assistant is playing this dance back and forth to not get in the way of the line of sight so that the robot can still work, where TMINI comes in above. So you set your cameras up directly above the patient. You don't have to touch the robot again. It's right there. It sees everything, and you can, change retractors, put an arm through the wound. It never loses sight. So it's very seamless. The ability for my tech to set the whole thing up in about 2.5 to 3 minutes, it's, just really does not impede the workflow at all. So it's just way more beneficial for a small hospital, as well as knowing what implants you're going to use that day. You don't have to have 20 different sizes. You have one. You already know what you're going to do before you go there. So it was really beneficial for us, especially, and I think anybody who's at a small institution or in an ASC where you're looking at, quick turnover, not a lot of room to store things. I think it's amazing for that institution, as well as, the typical hospital setting.
Shawn, can you pipe in a bit on the opportunities with robots, and then I'll push you a little bit on why robots at all?
Sure.
I'll ask that tough question to you.
Sure. Well, first of all, some of the delay is the fact that the literature, even up until last November, that did the largest, meta-analysis on conventional versus robotic knees for the same patient, we still can't prove clinical superiority, and we still don't have intraoperative changes that we hope to glean from future robotic information. From my standpoint, the facility I work at is an orthopedic only hospital. It's third largest outpatient and inpatient joint volume center in the country. Wilmington's where a lot of people retire, so we have a high volume 5,000 joint facility. And we learned through the evolution of the phase 1 robotics that they were essentially implant handcuffs. And so a lot of the cost of the robotic systems were based on unit sales. And the first discussion never looks like the renegotiation for your contracts for negotiations with implant costs second, third time around, once they know they have developed a practice pattern that's going to be hard to break within the healthcare system. We have 8 different surgeons, and we don't have a 2-vendor system, so we have a pay-to-play system. So when a platform came out that was open, that would allow anybody to use an implant of their choice, it also frees up the negotiations about cost of implants because you can divorce it from the technology. So when all that came together, plus having a robotic system that was part of the normal workflow, as was referenced before, where you're not bringing in something that is unconventional to what we've been using for years in a conventional setting, but doing it in a manner that is just more sophisticated and has smart instruments that parallel what we already enjoy in the operating room without robotics. That was the impetus for me to take a look into this. And in my early experience has been very positive.
Excellent. Excellent. Back to Jim for a second. Do you think I've asked this question of Alex privately? If you had the TMINI as your first robot, what would you think any other big box robots would be made? I say that about digital photography. If that came out first, would someone ever do film?
I think you're always going to have people who are going to want to look at different options, but I think I think everything, like you just brought up with the camera, everything gets better and better with time. And I think if you had this, much easier to use, it's very user friendly, especially with regular cutting blocks, regular saw, but still having the benefit of robotics. I don't know that anybody would ever say, oh no, I want to go with this bigger thing sitting over in the corner that takes up half the room. But I think with looking at what people have done in the past and then trying to take those ideas and make them better, I think that's what TMINI came from. I think it came from that. I think it came from an idea of not being handcuffed to a certain implant partner. I think that what they've come up with is a wonderful novel idea. But I also agree with you. I think when this technology hit, I think it kind of made a lot of the things that were done before, I won't say obsolete, but I think it definitely is better than what we were doing before. And that's speaking from a guy who, did the big box robot for years. My staff likes it better. The turnover and the workflow is better. And it really is a seamless transition from a manual to a TMINI with all the benefits of a robot versus, really learning a whole new setup for your team and a whole new procedure.
Right. Especially if you like a particular implant system. I'm not sure anyone could, if any of the 3 faculty or someone in the audience could tell us, what if I had a new implant, not a new implant, an implant that has not used Think before? Does anyone know the process of connecting with Think and saying, you don't just use the Think. So my understanding is you don't just show up with joint company X and say, oh, I can use this. There must be a process to get your joint company in line with Think. Could anyone comment on that, either on the faculty or the audience, what that process is? I'm wondering.
There is a process, Ira, and unless one of the Think staff are on the call and want to chime in, but they would want to connect with Think Surgical so they can get their CAD designs and the specifics of their implants and their cutting jigs and everything to them, so they can build that into the software and the program and get it cleared through the FDA as well. Obviously, there have been many systems already on it, so that path has already been set, but they would want to communicate with Think Surgical to get the specific dimensions of their implants and cutting jigs to Think Surgical.
Yeah, so there's a process, and I want to make that
Right.
clear, because a lot of people who are on here are maybe new to this idea of robotics, and they may think you can just, you can buy the Think Surgical over at Lowe's or Home Depot, right next to the DeWalt equipment, and all of a sudden you can use it on your company. But I think there's at least 8 companies either in or in the process, right? At least.
Yes, sir.
Yeah, that's a lot. That's a lot of opportunity. Um,
And
uh,
that's nice, Ira, because just echoing what Dr. Womack and Hocker have said, up till now with technology, we really, as surgeons, had to choose. It was choose the implants we want to do and probably not use technology, or go full in with technology and use the implant that that particular robot maker supplies. And so we had to make a sacrifice, honestly, which is interesting because prior to technology, surgeons were very committed to a single implant line, a certain philosophy, and committed to it and would never change. But then suddenly technology came and people chose technology over implant design. I think what TMINI is going to do is it's going to bring the pendulum back and let the focus now be back on implant design, because now surgeons can truly choose which one they want to use for whom. So with all the new alignment philosophies, kinematic, mechanical, gap balancing, with the different liner types and different implant designs of cruciate retaining, posterior stabilized, medial constrained, medial pivot, with all of these different combinations of alignment designs and implant designs, now with a single robotic platform that can achieve all of those things, I think it's going to allow surgeons now to get the robotic benefits they want, but also put the priority on the implant design they want as well. So I think there's going to be a shift in that priority now.
Yeah, I completely agree with Alex. I think that it takes that pendulum, but it's the perfect marriage between adding the technology and also adding choice. So, when you want to go with maybe a certain implant for a certain patient, or you're in a facility that has two different physicians that maybe want to use two different implants, you get that choice. You get to do what you feel what's best for the patient, but you also get the benefits of the technology, the benefits of a robotic system, and you get to marry all that together. So I think this is the first time that we've really seen that good marriage for the patient and for the surgeon.
we have a question from Russell the Bodner. Russ, you want to ask your question?
Sure. TMINI is groundbreaking as far as smart instrument hardware, but there's not much discussed about the software, the planning and navigation, the screens you're looking at. The big boxes are somewhat different. How does the TMINI software work, and how is it different from other systems?
Well, I can speak to that comparative to Mako. So it does have a T-plan software that you sit down with prior to your case. It'll let you look at the alignment. It lets you look at your cuts, your gaps, and you can change all that as you go. And so you can really dial in if you want to add a little varus to the patient, or if you want to, if you look at their anatomy and say, nope, that needs a little more slope. So there's lots of little things that you can dial in while looking at that 3D model that you can do before you go. And then, you kind of go in there, and it allows, I think, for you to just do the fine tuning in the operating room. You don't have to make big changes. Whereas with Mako, your NPS comes in and they pull things up in the operating room, and really it's kind of just making these changes as you go. And so I think there's a lot more planning, I guess, from my standpoint and my involvement, that TMINI allows you to do, as well as we have every option that anybody else has, and maybe more than some, with regards to when you're in the operating room. If you want to rotate the implant, if you want to take that cut up or down, if you want to pin medial or laterally, it has every option to do that and really fine tune the procedure, which is what we didn't have before when we were thinking manual. But I like being involved in every step of the process. I really like sitting down with the T-plan, seeing what my implants are going to look like on that patient's bone, and knowing that I feel like I had a real hand in setting it up. And then if I want to fine tune it based on how things look in the operating room, I can do that. So I think the marriage of those two things really does help. I don't know what Alex's thoughts are there.
You implant the X-rays, go into the software, and then you do your planning on those X-rays using the software, then register the patient intraoperatively, and then do some fine tuning.
Yes, sir. It's a CT-based system. So the CT goes to Think. They have a planner that will sit down and like for me, based on what they feel like my preferences are, they'll plan the case. Then I will look at their plan, make any changes I would like to do there, then go to the operating room. That plan is uploaded after registration. And then subsequently, I make any small fine tunes that I want to there, and then hopefully come out with a great result.
So image-based.
Yes, sir.
Wait, what is I have just remember speaking to some people from Think talking about a new system, a 1.1 system coming out. Did any of you guys know about that, Shawn or Alex or Jim? The
1.1 it's out now.
Oh, it's how now?
That's what I was alluding to when I said we can rotate the implants, pin at different points, really dial in anything you want to do with that implant. So it's great for folks who whether you want to gap balance, measure section, however you want, whatever your mindset is on how you want to balance that knee, you have every option available now. So it was a real leap forward, I think, for the software.
Excellent. Excellent. Marty, you had a question. Marty Nichols.
Yeah, I was just curious, how often do you find yourself, each of you guys, changing your plans interoperatively versus what you T-plan?
So what's interesting is, sorry.
No, go ahead, Alex.
With the 1.1 software, just to go back on your question, Russell, the things that really distinguish this planning software and the display is that it's a very large screen. It is a touch panel screen, so it's sterile with a drape on it. So either the surgeon can do it or an assistant can do it either. But the layout has been made so it's very simple to use. You get the various planes of the knee in basically 6 different angles, and you can actually rotate those images because it's CT based in 3D. So you can see where the implant's sitting, whether it's notching, how your changes are taking place. So it's not a static platform. You can take the images and see real time how your changes are making effect. And then with 1.1 IRA, as we're talking about, that's where we can do gap balancing. We can measure the distances and the gaps with stresses so we can see how our changes will make effect on the overall construct of the knee. And so because it's easy to do, because it's very efficient and effective, Marty, basically what happens, I end up making a slight change in the majority of the cases. So some competitive robotic platforms out there, there's some people who say that probably 70% of their plans don't get changed at all, meaning whoever's engineers putting together their plan, whoever's putting together their robotic software, it's done. And then the surgeon just execute that and does not change it. I find that at least with TMINI in my hands with 1.1 software, it's so easy to make a rapid assessment that I can make fine-tuned adjustments to really get that knee to be balanced exactly how I want to. So for me, it's so easy. I end up making slight changes almost every time.
I completely agree. I will make some every time. I will rotate the femur a little bit, pin medial and add maybe a little varus, something like that. But like you said, you're tapping a screen. So it's extremely easy. If you don't like what you did, you just hit the other button and take it back. So it's very simple, and you get to see what those changes do automatically.
What I was going to say about the planning, I'm a measured resection surgeon. So my normal workflow is look at the x-ray. I see the wear pattern because I have a formula that's successful for the wear pattern on plain x-ray, then look at the CT scan. And the thing I really like is that you can look at your actual resection. So you put your surgical plan in, and then I can, for a lot of times, my depth of resection, I can look at the cuts with the implant removed. So you're actually looking at what your cuts would look like after resection, which I find very valuable. Now, Marty asked, how much do you change? I haven't had the benefit of the 1.1 experience yet, looking forward to it. So I've been using the non 1.1, and I have changed. If the thing that I would change most often, it's rotation, especially on valgus knees, making sure that that I'm externally rotated. In the current software, it's hard to find white sides lines from a topographic experience on the CT scan versus your visual eye on the trochlear groove. So I did make some modifications on that. I typically don't do soft tissue releases. I will recut, put in more varus if need be, or slope and tighten flexion. And so I've made some of those cuts manually, but having the opportunity, as these guys are explaining, to do that with sophistication in 1.1 is just another added bonus to what's already advantageous.
It's great. Russ, you had another question there.
Yeah. One of the things that I'm most interested in with robotic platforms and soft tissue ligament balancing is how stresses are applied to the knee. There's different types, manual, which we have always done, spring loaded with a given tension or a variable tension. I'm wondering how the surgeons operate if they're using different implants. Does they just use whatever is recommended by whoever implant they're using, or do you use a certain strategy yourself for ligament balance?
Who wants to take that on?
I'd
I
be
still
happy to do
stress
that.
them manually. Yeah, no, go ahead.
No, I'm just saying that, most of the literature supports a medially biased balanced knee. It means that you preferentially want a medial compartment, especially for stair climbing, elevating. So my design with an ultra congruent allows me to maintain that normal anatomic bias towards the medial side. But that's definitely implant and surgeon preference driven. And that's the one thing that I think the numbers will help you reproduce what you would like to reproduce. There's no empiric number that we are all shooting for because we all have different goals. And as was pointed out before, with the emergence and popularity of kinematic knees that are throwing a third paradigm that are having pretty good results in these early and midterm follow-ups, that I think the goal may be both surgeon and implant design driven, that you may have a different plan based on both those variables.
Excellent. John DeJarid, you had a question for us, if you want to do it. Otherwise, I'll ask the question for you.
Oh, sorry, I'm enjoying the last few degrees of fall here in Chicago. I was just curious about, sorry, I'm just humbly asking, I'm not a surgeon, I'm just a rep, but just humbly asking if surgeons are like really are a DePuy or maybe a Palmetto or Stryker. Palmetto, that goes how far back I go. But if you're with those companies and TMINIs with certain companies, and Zimmer seems to be aligning themselves with that company. I was just curious if you're one of those surgeons, and I was actually curious about how, if you're a Mako surgeon or any other robotic surgeon, how you deal with the finances. If you really love TMINI, to get it, like how do you do it financially if you're going to switch from Mako to one of the big box to TMINI? Like, how do you?
So you mean,
You
so
don't
if
have
I
to buy an.
yeah, if I could summarize it, because we're in the middle of one of these contracts right now, and
Yeah.
so you have a 4-year lease. You have a 4-year lease on a big box robot, right?
Okay.
And you're using big box company, okay? And then you decide to do a TMINI in the middle of your 4-year lease, which may have a buyout at the end. So
Okay.
the question is, have any of you guys experienced that? Because I think, Jim, you already started with Mako. How did you just did you sell the Mako down here on Jerome Avenue in the Bronx? I mean, you can sell anything here in New York. You can sell anything.
We still use both. We had already paid for our Mako at the time that TMINI came along. And what's nice for us is it's kind of transitioned from, in the beginning, I was doing more Makos and then started in with the TMINI, but it allowed us to basically do joints in both rooms because, like I alluded to before, it's a real pain to move the big box robot from one room to another. And so we were able to kind of do one robot in each room. And then subsequently, as we've become significantly more fond of TMINI, the Makos have kind of faded away a little bit. And so we'll still do, if somebody comes in and I've done a Mako on their other side, we'll do a Mako on that one. But really, TMINI has really started to kind of overtake that, just because my people in the OR love it. It is significantly easier for them to set up, easier for them to move. And it's an easier robot I mean, the girls in the OR love it. So it's just an easier thing for them to work with, as well as, I really like the results I get from it. So I would say that's, we're luckily enough, we were already kind of through the Mako phase, and then we're able to get a second one, but we still use them both.
All right. I hope that answers a bit of the question. I think you're just going to have to do sort of some type of negotiation. Really, in the end, has been my experience, because we are in our hospital, we are a Mako house, a Stryker house, but they surprisingly, my joint surgeons came up to me the other day and said, we'd like to trial the ZB with the Think Surgical. And I only say surprisingly because just 2 weeks earlier they said, we want to make sure you're still committed to us using Stryker. And then 2 weeks later they came up and they said, it's surgeons. I expect that kind of erratic behavior, and they literally came up to me and says, would you mind if we do 2 or 3 cases with the ZB and the TMINI? And I said, well, I don't know if it's available yet. I really don't. Specifically, it's FDA approved yet with ZB, but with Zimmer Biomet. But I said, sure, we'll figure it out. We have enough volume to carry it.
Or would you ever consider like one of the smaller companies that are on the platform, or is it only Zimmer Biomet?
Well, for me,
we're talking about like Link and things like that, or smaller companies. Yeah.
For me, just so you know, I just recently retired from the OR, at age 32. No, just kidding. I just was recently retired from the OR, and
Me too.
5 years. My last 5 years, I used a small company, a medial pivot knee, because Stryker did not have it, and I really believed in it. And I probably would turn that company onto Think Surgical now. I think the smaller companies are superb. I mean, there's a lot of innovation in the small company. This is one person's opinion. I mean, I don't, you guys could feed in, there's innovation everywhere, and some really great implants.
Just to update you, Ira, ZB is live on the Think platform. So we've done 30 here in Fremont, and so we're doing more each week. And there is a medial pivot company on the TMINI system coming as well. So if you're a medial pivot implant surgeon, that is available now.
Yeah, so that just answers the question right there. I mean, that's what happens when you get out of the OR. You don't know this stuff. You just sign papers that say, yeah, approve this, approve that, So as a chairman, actually, I don't make the decision. We have a rule. The surgeons make the decision, and I do the negotiation. And that's how we do it. It's called return of the surgeon, like Return of the Jedi. Return of the surgeon involved. Alex and Shawn, there's some slides you guys sent me, and if you don't mind, I'll bring them up. Okay, I even brought up my list of Star Wars. Return of the Jedi. I had to remember what that was. But let's do yours first, Alex. Could everyone see this slideshow here? Play from the start. Is that it? Is that come across?
Yeah, we can see it.
All right. Tell me when to change slides right now, huh?
Yeah, you can advance now. So just to give you an idea, for those of you who are not familiar with the TMINI system, that's really the handheld robot on the left. So it's miniature handheld. It's very familiar tool, very ergonomic, things we're used to as surgeons to use. And that drill only turns on when that pin is going into the exact plane that you planned on the CT scan and updated with the robot. So that is the robot on the left. And the base station is what you see in the second picture with the overhead camera. So what's unique about this system, because the camera's overhead, the line of sight is directly overhead. So your assistants, your retractors, everyone can be wherever they're usually placed around the surgery. You have all of that real estate to use. They're not trying to dodge out of the way of the camera, or things aren't getting interrupted in stalling the surgery because they're blocking line of sight. So the overhead camera makes a huge difference because all the trackers and digitizers and the robot itself aim directly upwards. And then you can see the registration platform and the CT planning on the right. I think the next picture will show that as well.
All right, there you go.
So here's an example of a plan. So this is the T plan Dr. Womack was referring to. So it's a CT scan based platform. So you can see from hip to ankle, you can see the implants placed. And then this is just one screenshot, but basically you can take the femur and take the implant off. You can have the bone on, and you can have just the bone resections. You can see the depth and the slope, and you can basically change it, both implant size and position on this before surgery if you like. It's done by engineers ahead of time, and they're nearly right on, but you can make fine-tune changes if you like on this T-plan platform ahead of time. So this video, if it's coming across, will show those trackers. You can see that they are straight above the camera that's registering them as above head. So your assistant's going to be wherever they're normally standing around the table. And then that's the screen that shows the gaps being bound or gaps being obtained. So you can collect maximal gap, opening, inflection, extension, medial and lateral sides. It will save it automatically. And then it'll tell you both how much bone you're resecting with your current plan and what your residual gaps will be. Perfect. I think you go to the next one, Ira.
Okay. There we go.
And then this is the screen. You can see how you have the 6 different angles to see the knee, 3 of the femur, 3 of the tibia. You can rotate those images 3-dimensionally so you can see in different planes, but you can rotate the implants, move them, adjust them, and there are 3 different anchor points. So you can anchor just one side, medial side, lateral side, or the center, depending on how much change you want to see with the various varus, valgus, or rotational changes. But then you'll see live how that will change the resection, bone resection, and the gaps. And so you can see either I can do it sterilely or the assistant can do it for you, whatever you prefer. You can go to the next one. So if you haven't seen the TMINI in action, what I don't know is how that camera translates the plan to that robot. That's where the technology is pretty amazing. So whatever changes you do, it instantaneously changes to the robot, and then it places the pin. So just like a drill, you're holding down the trigger, but the difference with this one is it only moves forward when you're in the exact plane that's planned. So you really can't miss. And so it's on plane, you place the cutting jig, and then you do your distal femoral resections as you're used to. So what's nice here is you get to use the saw, you get to use the tools that you're used to, you get to use your normal workflows. You can cut tibia first, cut femur first, whatever you like. In this example, we cut distal femur. Now we're preparing for the 4-in-1 block. So we place these pins in the plane so we can place an adapter specific to the implant company being used, because that will then place the 4-in-1 cutting holes for the pegs. So you can see we place that where we want it, and then we do the drill holes for the ensuing 4-in-1 cutting block. But then you get to use, again, the cutting jigs you're used to, you're familiar with. You get to have the saw in hand. You get the tactile feel that you're used to in terms of completing these bone cuts. With some of the robotic procedures or other technologies, either it can be difficult to feel when you're cutting through bone, or you're cutting through a jig and it's just more challenging to reach. But here we've finished our 4-in-1 cuts, and now we're going to the tibia. And so same thing, you place 2 pins that will place the cutting jig at the appropriate depth and angle that you had planned on the CT scan ahead of time. So what's nice here is, again, because we're using tools we're used to, because we're using jigs and the saws we're familiar with, we can see and feel the resections as we do them. Again, with some of the bigger robots, I find it challenging to see what I'm doing just because of their large, robotic arms or platforms that are in the way. You can move on to the next one, Ira. And then lastly, once your implants and trials are in, you can use with the 1.1 software to reassess your gaps. And so you can see how the medial and lateral side compare in flexion and extension. And your final outcome there. And then it does have this screen where you can assess gaps. So you can assess it not just in 0 and 90 degrees, but you can do it at all range of motions. So you can see throughout the ranges from 0 to 120 degrees. It'll tell you your medial and lateral gaps and how equal they are with quick range of motion.
Wow.
You can move to the next slide. Yeah, very user-friendly. As I said, easy to see, user-friendly. Just some examples of some procedures we've done, whether it's varus or very varus. You can plan it ahead of time. You can use whatever alignment philosophy you want, whether it's mechanical or kinematic or functional or gap balancing, whatever you prefer, but you can make some significant corrections, as you can see here, varus examples. And on the next slide, I think you'll see some valgus examples as well. So again, it gives you the opportunity to make the corrections you want to and assess those balance live during surgery.
This person has one more joint left, I hope maybe next
That's right.
week we'll see the slide and we'll see the completed case,
Hopefully so.
Seems unfinished to me, Alex.
That's right.
It's the end of that slideshow there. So in a way, this is sort of like Return of the Surgeon, Return of the Jedi. You're really doing surgery in a sense.
I think you're right, Ira. Puts the choice back to the surgeon, lets the surgeon choose how they want to do it with the technique and the implants they want.
Yeah. Shawn, you want to make a couple of comments on this case here?
Sure, and I thought that was a great review on the quick and dirty of how this quick system is implemented pretty quickly from a conventional instrumentation to a robotic. But these type of cases really shine when you can't use conventional instrumentation. Historically, my options would be a navigated system or a PSI where they have a 3D printed customized block to try to get a better alignment. Here, I had the benefit of getting the surgical goal that I wanted, plus having the ability to make intraoperative changes by using the TMINI. So this guy had a fully femur encompassing recon nail that had some malformation at the malunion at the proximal femur, which changes the alignment. And so the system was adequate to adjust for that, and was able to do this without anything different than a primary total knee with the same outcome. So this is another example where not having to rely on conventional instrumentation to bypass that liability, I think it really shines well. The implant, while it looks like it's in varus, is actually adjusting well for the malunion of the femur, and because you're really balancing between the condyles, and it ended up well. And based on recent kinematic knee X-rays, that looks pretty perpendicular.
Right. Absolutely. Absolutely. Hold on a second. Let's just say, hold on. That's for later. Jim, this case.
So yeah, I completely agree, and I think Alex did a wonderful job of kind of going through the steps of the procedure. And I think this is where kind of looking at your T-plan idea before you get an idea of the overall alignment of the leg, you get an idea of what you're kind of dealing with, and maybe where you want to go with your cuts and things. Then when you actually get in the operating room, you get the ability to stress those ligaments. You get the ability to look at your gaps, make some small changes. But I think you can really take this as kind of the knee that comes into our office all the time. Bad medial wear, this varus pattern, and then in a 35-minute tourniquet time, you can come out with a great result. Plus, I really think with the precision of robotics, the cuts are so much more precise. It allows me to have a better feel for press fit. I feel like I like press fitting more and more as we get the cuts better and better. So, like I said, this is kind of the typical run-of-the-mill varus knee that comes into my office, but it's, this is an easy correction. Whereas before, you've got the intermedullary alignment guide, and, you cut, maybe you love it, maybe you don't. You're maybe recutting something or doing soft tissue releases to balance this. Now, I very seldom touch the soft tissues. I'm really like Dr. Hocker. I mean, we plan the cuts, we make the cuts, and it looks good when you're done. Plus, you get to pick your sizes before you go, so that you should be fitting this thing like a glove.
That's excellent. I just wanted to point out, Think Surgical. This is a sort of a advertising moment here. I'm a radio disc jockey right now. is going to be at AUKUS. Register for a symposium. Stop by booth 506 for hands-on demonstration. And they'll be there November 8th for this. So I just wanted to add that in. I'll stop my share for now. Yeah, so that's a lot of questions here. Okay. Brian McGrath. Hey, Brian, how are you? You had a question about the trays.
Oh, hey, Ira. Thanks, guys. I really like. Hi, Alex. Hi, Laura, Beth. Stuart's done some great stuff here. I mean, you guys have been working on it for long enough. I mean, it's really brilliant, and I love the agnostic feature of it. Yeah, I have two questions really, since I got to turn my camera on. Anyways, well, the first one, and Alex, you already answered. Just add one more tray, but you think you reduce the number of trays or sizes of your trays if you're going to mess around with your tibial or femoral components for your trials. But what do you think about what's going to happen with the other robot companies and this agnostic robot? I mean, are we changing the landscape, or is this another flavor of ice cream that people are going to have to will be able to adjust to or utilize? And then the follow-up of the other great question on cost. Right now, robots are basically inexpensive because we rebate them. And now, are we going to change the price of implants? We're going to lower the price because the cost of the robotic system is going to be less?
So what do you guys think?
Brian, great to see you, and all great questions, and definitely worth discussing. I'll chime in, and obviously Dr. Womack and Dr. Hocker can speak as well. In terms of the tray, number one, it is a single tray, and then because with the CT scan, I have yet to change the size from the plan. I don't know if the other two on the panel have ever had to change their implant size, but because of that, even if you do, it's probably one size up or one size down. But now, instead of opening up a femoral tray of all the sizes, the tibial tray of all the sizes, and all the cutting jigs, you really can peel and pack just the trial that you think you're going to need, and the cutting jig for that respective trial. So, in terms of turnover, now you're not turning over 9, 10 other femoral sizes, 9, 10 other tibial sizes that you never even use. So, in terms of wear and tear on those, in terms of the ASC turnover, especially, it definitely makes things faster. So, it is definitely helpful to be efficient. Also in the main hospital, but definitely ASCs. The second thing you mentioned was being open platform. This is certainly unique, right? This is throwing the whole discussion with administrators and robotic companies, implant companies on its head, because you're absolutely right. Up till now, as you mentioned, if someone wanted a robotic knee, they were just going to get whatever implant that institution happened to have the robot type. So, but now you can actually choose and have different ones. Not only can a single surgeon use different implants, but a single institution of different surgeons who want to use different implants themselves can now use different implants. So because they have so many different designs on it, it really does give the Think platform a lot of flexibility. And I think that will definitely change the discussion, because as Dr. Womack and Hocker discussed, these being handcuffed to current big box robots and being tied into 4 or 5 year contracts, I'm not sure that is cheaper. I think that is much more expensive because they're being locked into long-term commitments. But here, now you can actually go to administrators and talk to them about different implant companies. You might be able to talk to administrators about lowering costs, talk to the implant companies about lowering costs, because now competition is much more real because so many platforms are available. So I think that's going to completely change the financial discussion. The third question was a good one, Brian, but I can't remember. Remind me of the third question.
Brian,
Just the idea of whether or not this is just another flavor of ice cream.
Oh, right.
I mean, a great ice cream, but all of them, we can't prove that, me with a saw and jigs is not as good as the robot. I mean, I use Mako.
Right. Yeah.
Buffalo is the origin story for all navigation with Ken Krakow.
Right.
And so some of my partners use navigation, which is much like Stuart Stew's, TMINI, which is, the only real difference I think is the fact that it's robot based in the software and integration with in the OR with the sterile screen is a real improvement over even NAV. And then the rest of us, like Rashala, I mean, they're banging out 800, Mako knees, in a year. So we have a mix of people in our hospital. A lot of it is Stryker. But I can see people staying with one and staying with the other. Or do you think it's going to change so dramatically that, like Zimmer Biomet's now, has some relationship with TMINI? Is that going to be an exclusive relationship? I imagine that's to be worked out. But where do you think it's going, relative to all the surgeons? And, do you think you like it so much more? Or is it because you guys are early adopters that this is sexy technology?
I knew it was a good question, Brian. That is a great question, and I think that really what's exciting about TMINI, at least for me, is that it truly is different than the other big box robotic technologies out there. So other robots have been out there, and it sort of is a me too robot, or very similar with some of the similar disadvantages of the other big box robots. This robot really is different, being handheld and wireless and so compact and easy to use. I'm excited to see how it is adopted, because as good as the robotic technologies are, as you described, it's only used in about 12, 15% of the cases being done. I mean, as good as they are, and we're talking about all the time, it's really used in the minority of cases. I believe this technology has the opportunity to really be the robot for the masses. The reason is because it's so easy to use. It's familiar to surgeons. This is how we were taught to do knee replacements. It's with tools we're used to. I honestly get worried about these fellows and residents who only know how to do a Mako knee, because when that Mako doesn't work, I'm concerned that they don't know how to finish that knee with manual instruments. What's nice about this technique and technology is TMINI is a natural transition to put robotic technology in the hands of really any surgeon that does typical knee replacement. And now that you can do it with any implant you want, I am very excited to see how much larger that number will grow in robot adoption. I don't think the robots didn't adopt because it didn't do well or results weren't good. It was because of all the disadvantages of its large form factor, being bulky, being expensive. This system really addresses all that. So I think there's a huge opportunity ahead for every surgeon.
I think one of the best ways to answer that question is the current big box company that you guys are referencing the most. I won't name the names, is coming out with an agnostic robotic tool as a copycat. So they're changing their paradigm from their implant only specific to having this option going forward. And I think that, that market analysis speaks for itself of where this particular unique technology is going. To answer the question about the trays, I use a system that has same femur, same tibia, no right or left. So we can actually get our implant trays down to one tray, and then you add one tray for the robotics. So you're looking at a 2-tray system. So it's pretty simple. The last thing I will just say that I will echo what Dr. Womack said about the precision of the cuts that makes them feel comfortable for press fitting. I'm a cementer, and this is and the reason why, especially with this technology, I think cement is a great fine balancing tool, and I can use the cement in my final construct, keeping the raise on till the cement's hard, to direct the cement mantle to fine tune for balancing of the knee. So it's also useful in the conventional cement capacity as well.
Jim, it's like most JOEI topic sessions. They start off and they get to the end. This is usually the fastest hour in the world. The last inning of baseball takes forever. The last 2 minutes of football takes forever, but JOEI topic sessions go fast. So, Alex, you gave a great summary statement. Shawn, a great summary statement. And now I'm going to ask Jim to bring us home in the last minute with some summary statements about everything we've talked about, Jim.
So I think we've discussed a number of topics with regards to TMINI versus other things, with where does TMINI fit in the robotic space. And I would say I completely want to reiterate what Alex says. This is the robot, I think, for the masses. This is the robot to get those other 85% of folks who maybe aren't doing robotics coming this way. nobody's saying Mako users are going to all switch to TMINI or any of that. What we're saying is, and if they want to, that's great. I think it's a great technology, but this is a comfort factor of doing what you're used to, doing how we were all trained, and using the tools that we love to use every day. By using this system, you can still use your cut guide, still use your regular saw, and get every benefit to robotics. So this is that comfortable home feeling that I think we all want. And so I think this is the transition from either the manual knee to robotics, or for folks who maybe haven't looked into this space yet, I think this is the gateway to get them there.
Excellent. So I will, sum up and first of all, thank our panel, thank all the participants, everyone. I really appreciate everyone taking the time on a Wednesday night. I'm going to give a shameless plug. This year at the Academy, there's going to be yet another JOEI mixer. So if you were one of the 330 people who missed last year's JOEI mixer at the Academy, I think we're going to turn into an event company rather than a publication. But either way, I think I really enjoy everyone's engagement, and I want to say thank you so much to everybody and call it a night. It's 9:01 exactly. So thank you.